all of these interventions that address the social determinants are important, but to achieve maximum efficacy, they have to work together.
As researchers, we often design studies to answer questions and get answers that then we think are going to make the difference. And I think if we want to make a difference, we have to think about those all those layers and those contexts that we can then adapt and apply that evidence or that information.
Well, I think the evidence is growing that we have to think move beyond the biomedical model when we're treating anyone with an illness. We don't just think about, this is the virus they have, these are the right drugs, this will help their cholesterol and that won't. You have to think in some, but maybe not everyone, about the social context of, do they have a roof over their head? Do they have food on their table?
And we know that education is important. People who have more education live longer. We know that income is important. People who make more money live longer and do better. So always ask for a raise, don't give up that opportunity. And even within racial ethnic groups, the more money you make, the better you do.
Because it's not just the housing, but it's also the mental health treatment, it's the addiction treatment, it's having all types of support so that people can stay on treatment, be more consistent, feel that support, and get on a road to having a better life and getting out of some of the bad situations that they were in.
You cannot easily tackle one problem without being aware of and perhaps even addressing several problems at the same time. This makes it complex, but the benefit can be huge, because if you can correct one or two issues, you may return someone not back to physical health, but full social health.
The problem with the disparities model in and of itself, if that's the frame that we're looking at to try to understand health inequalities or health inequities, is it looks at the differences. And the differences typically happen downstream, right? But I like to pull it upstream and look at what are the systematic and the structural factors that give rise to those differences. And the reason that I think it's important is because wherever we look at the problem, that typically tends to be the same place where we look for the solution.
We spend a lot of time talking about age, sex, race, ethnicity, social status, culture, religion. Those things you can't do anything about. I mean, you can't change my color, and I happen to love my color, right? But we talk about black and white differences quite a bit. But the things that are important are the ones that are modifiable through program intervention that government has some control over. So education, behavior, risk factors, employment, income, wealth, health insurance, and health services.
Expanding Medicaid really changes the flavor of the program to go from a disability program to going to an early intervention and prevention program. This allows us to reach people who are newly infected with HIV. This allows us to reach people who might be at risk for HIV but aren't yet infected. It provides a chance to relieve pressure on safety net providers by getting people insurance and getting people into primary care. It also contributes to timely access to care.
But this connection between housing as a structural intervention and positive health outcomes, that's been proven now. We've demonstrated it now. There's not an argument in my mind and many others that are here that we clearly have the evidence. What we now need is the investment. So we have the evidence, now let's invest in the right interventions because we know they work and they're going to be effective. So let's do that.
It isn't just having a finding and saying we can just go to a community and say, here's the magic bullet or here's the magic, this is evidence that if you just applied it, it'll make a difference. It's then working with the people in their community, with the systems, and understanding how you train and have fidelity to that intervention or those approaches or that program, and how you work then across these programs and people to make it happen.
It's when you go somewhere else, it's actually helpful because people do things differently, and we often use the fact that the policy context is different to suggest that we shouldn't look at other things, right? It's like, well, it's different in Europe. They have a more robust welfare state. And it's like, no. Look at what they're doing and figure out how we can adapt it.
When you're in the same space and you're hearing the same challenges that we face, but also the successes, get energized. And it re-energizes you and ignites your passion to why we do the work that we do.
Brings together community advocates, clients, people living with HIV, community-based organizations, frontline service providers, researchers, policymakers, as we saw at this meeting, persons from HHS and from the White House coming. It's such a great blend of all the people who make the response to HIV a complete response. And without all of those voices at the table, we're really missing a comprehensive response. And this is one of the few meetings where all of those voices are present and together, and that's why it's one of my very favorite conferences.